Well, thank you very much indeed. I have been involved in FT policy from the very, very beginning. For those that don't know me, and there'll be a lot of you, I helped set up the original monitor with a guy called Bill Moyes back in 2004, and was around at the point at which the original legislation in 2003 went through both houses of Commons and Parliament. And I, like Chris, I'm a huge advocate of earned autonomy and the FT policy and the FT concept, and have worked for many years, first of all on the authorisation side, and then on sort of the oversight of the FTs, and lastly, in the last sort of 4 or 5 years that Monitor was in existence, on the sort of the more sector regulatory side. And I was appointed a few weeks ago as Deputy CEO and Executive Director of Regulation, which means that I continue to look after the FT sector. I will be looking after the competition side going forward, and also our legal team. So a lot of the old Monitor sits under me. But what I'm here today to do is talk a little bit about NHS Improvement and what has been created and why, and how we're going to operate and what is going to be different. But as I say, I've got a long history of working with FTs and the FT policy, and I'm a very, very big supporter of it indeed, and indeed the role of the governors and the governing body in that. So what I'm going to cover over about 15-20 minutes are sort of 4 key areas. A little bit of context. Now, I've seen Chris's presentation, and I'm not going to go through the context in as much detail as I think Chris did. Obviously, it is a very, very challenging context, and we'll talk a bit about that in a couple of minutes. Talk about NHS Improvement and what it is we're going to be doing, what's going to be different, what's going to be similar or the same. And then talk about the role, the governor's role, and how we can support you, albeit I think a lot of the support will come from Chris and his team, and then a few closing remarks. So let's start with the context. You don't need me to tell you. You just need to watch the television, read the newspapers, just how challenging the current context for the NHS, for healthcare in this country is. A few key headlines, starting with the money. Now these are figures for the whole provider sector, because NHS Improvement brings together Monitor and the old Trust Development Authority, so these are aggregate numbers. At month 9, that's the end of December, so 9/12 of the way through the financial year, there was a £2.26 billion deficit on the provider side. I don't yet know what the full year numbers are going to look like, but they're not going to look pretty. Somebody said 95% of FTs are in deficit. Not quite true. 75% of the sector is in deficit. That's 179 providers. And about 65% of the sector are forecasting a full-year deficit. And there's a whole range of reasons for that, which I'm not going to go into, but I'm happy to take questions on that later or at the coffee break, which I think is following my session. Operational performance. Obviously, operational and financial performance are inextricably linked, but operational performance has also been very challenging. Q3 performance on the sort of the key A&E target, 90.7%, against a 95% standard. A&E performance, like the financial performance, has been on a downward trajectory for quite a few years now. RTT, the 18-week target, again, it's not quite as badly off as the A&E target, but for the first time over the last 6 or so months, we started to see the sector miss that target, with performance at the end of December at 91.6%. And then quality. And in many ways, this I think is one of the biggest concerns that I've got, is that if you look at the CQC's ratings, and they haven't rated every single provider in the NHS yet, but a very, very high proportion of them are either requires improvement or inadequate. There are 16 trusts in total, in special measures, which is the most extreme form of sort of quality problems, and where I spend a lot of my personal time trying to ensure that we get some of those organisations back to where they need to be in terms of providing high quality care to patients. But so you look at all of this, the money is in a very bad place. Operational performance has been declining and continues to be hugely challenging, and the quality as graded by the CQC is not where any of us would want it to be. So 1617 we really do see as being a platform for change. That it needs to be what Jim, who's the new CEO, Jim Mackey of NHS Improvement, says is a fire break year. We've got to get the system back onto its feet. The spending review, compared to many government departments, was actually a pretty good result for the NHS. The problem is that the demands and the growth in volumes continue inextricably upwards. But the system got 5.4 billion cash settlement in 1617, rising to 8.4 billion by 2021. Those are nominal numbers, including the impact of inflation. So, more money. Many will argue not enough more money, but more money. A national tariff that Monitor, working with NHS England, sets that, for the first time, I think is more favourable to providers. The efficiency factor, that is the sort of the percentage reduction in costs effectively that the providers have to deliver, is at a much lower level in 1617 than it has been for many years. For a number of years, the providers have been asked to do sort of 3.5% or 4%. For 1617, it is at what I consider a much more realistic figure of 2% for that year, and that hopefully will start to redress some of the very significant financial issues that we have got in the sector. Now, in order to try and put that fire break in place, we are putting in place control totals for 1617. That basically is setting a budget deficit or a budget surplus for the provider side to go back to that word fire break, put a fire break on the financial position of the sector. I don't yet know what the total 1617 position is going to look like. The plans are all coming in at the moment, but those control totals are designed to make sure that we manage the system more tightly, more grip, to ensure that we hit the overall limits that Treasury set the Department of Health for healthcare. The other thing that has been included in the settlement is what's called a 1.8 billion Sustainability and Transformation Fund. That is more money that in effect will be allocated to the provider sector to address that sort of 2.2, 2.3 billion provider side deficit that we've got. So 1617, a year of change for the provider side. What are we here for? What does NHS Improvement do? Well, we have an oversight role, not just of the Foundation Trust, that sat with Monitor, but now for the NHS Trust as well. That came in from the TDA, as well as continuing to oversee the independent sector through our Monitor regulatory powers. And that sits in the bit of NHSI that I run. There's about 96, 97 independent providers that have got a licence that we also regulate. We increasingly will offer support to these providers to give patients what they demand, which is safe, high-quality, compassionate care within health systems that need to be financially sustainable. And we will hold... So a lot of NHSI is about supporting the sector, but there is also a need to hold to account boards of directors, trusts, when things aren't proceeding in the way that we would want. But a lot of the NHSI ethos will be about supporting the sector and only intervening with regulatory powers when absolutely necessary. NHS Improvement is going to be just under 1,000 people. It's a culmination of a number of different bits of the previous landscape. Monitor, which, as I said, regulated the FTs and that you would have had a relationship with in the past. The Trust Development Authority that brings somewhere around about 90-ish NHS trusts, those that haven't achieved FT status, into the NHSI fold. And then there are 3 areas that are coming in from NHS England: patient safety, the intensive support teams, and the advancing change team. And a lot of that is about this concept of improvement and support to the sector. Things like ESIST are in the intensive support team. ESIST is the emergency care intensive support team, a number of people that can help providers, help foundation trusts improve their ED, their A&E performance. So, it is all about support and improvement. We will work with providers and indeed systems, and one of the questions that Chris was asked was about social care and local authority budgets. The FTs, the non-FTs, all work in really quite complex local health economy systems, and I have to fix some of our most complex trusts, some of which I know you represent in the room, and where we have really, really big problems, they're often not just problems within the provider, they're problems across the entire system, and we can't find a solution to what's going on in a particular individual FT without also providing solutions to what's going on in the local health economy itself. Boards will be held to account against transparent expectations. That has always been the philosophy that we've had at Monitor, and that will continue. And we will only intervene, we'll only use regulatory powers when it's absolutely necessary. We will look to support the FTs and the non-FTs first, and only if it's absolutely necessary will we use our legal regulatory powers to take action. And we'll be looking for greater and more intense collaboration across health and social care systems, working with the key partners that really are the CQC and NHS England and the commissioners. Some genuine shifts in emphasis. Again, genuine support, national and local. We're going to have a much more regional focus than we've had in the past. We are setting up 4 regional teams. There'll be about 100 people each in the north, the south, London and the Midlands and the east. They will be much closer to their counterparts at the CQC and NHS England, and more importantly, they'll also be much closer to the trusts that we oversee, the FTs and the NHS trusts, allowing us to provide on-the-ground support and help for the provider side. Very much acting as a critical friend and a supportive partner to address the efficiency, quality and access challenges that they face. As I say, there will be a different balance between support and regulation. Coming from Monitor, we were very much a regulator. We didn't play a big part on the support driving up improvement. So the regulatory impact, the intervention will be proportionate and only when absolutely necessary. I'll talk a little bit about some of the support packages, but I do think that one of the really big areas, and it's probably one of the biggest strategic challenges the NHS faces at the moment, is to support leadership and succession planning. We've got a very challenging system that we have in this country, and there needs to be as much support and help for our leaders, our chief execs and our CFOs and our medical directors as is possible. And part of the NHS Improvement team will be looking at what we can do in this area. The focuses for NHS Improvement going forward take you back to an earlier slide about the number of trusts that are graded by the CQC as being either requires improvement or inadequate. So one of our objectives over the next 3 or 4 years is to drive up the quality of the sector to get as many FTs and NHS trusts into the good or outstanding rating. There are, I think, only 2 trusts currently graded outstanding in the country. There is a third on its way, but I'm not sure it's been announced. But that is it's been announced today, has it? So the other 2 are Frimley, which is an outstanding organisation, and Salford up in Manchester. But we need more outstandings in the sector. We need more goods because, as I say, there are far too many that are either in special measures or requiring improvement. A second key focus is to drive these 16 trusts that are in special measures out of special measures and improve the quality of care that they're offering. A key focus will also be a more strategic, the strategic direction of the 5-year forward view. We've got to focus on new models of care and local health economy solutions. Sustainable achievement and long-term performance of the targets and standards, something that the government is rightly very focused on and very concerned about. We've got to get those key targets in A&E, RTT and the cancer targets moving in the right direction. And we've got to get financial control of the sector. And that really isn't just about grip in the short term, it's about improved productivity and efficiency. And I'll talk a little bit about some of the Carter recommendations in a minute. And then support for the leadership, the boards and the leaders of our organisations going forward. Now, I'm not going to go through all of these. Here are just some examples of the programmes that are in place or being set up at the moment as part of NHS Improvement. Some have come in from NHS England or the TDA, some have been developed in-house, but there are a number of programmes that are in development. The first NHS Improvement board meeting is next week, and I'm sure one of the key issues of discussion is going to be, what is the strategy for improvement? Where do we focus? What will ultimately be limited resources that we've got to help the system improve in those sort of 3 key areas of access, quality, and the money. There is going to be what I call a shared definition of success going forward. Both the TDA and Monitor had their own framework to judge performance. I won't go through this in a lot of detail, but it fits into the areas that you would imagine. Quality, we will be using the CQC's quality ratings, and success will be to get those up to good or outstanding. Finances and use of resources, key obviously to delivering against the money, which we're developing with the CQC. Operational performance, a small number of the core access targets will be in there. And then something on strategic change, which is about working with NHS England and the delivery of the 5-year forward view. And then this key thing about leadership and improvement. So we'll be publishing a document in the next couple of months that sets out the framework that we will use to oversee the provider sector, but it will be based on those kinds of concepts. Now, something that I think is very dear to Chris's heart and to mine and to Jill's, which is a return to earned autonomy. We're absolutely committed to getting back to earned autonomy. A vision where local decisions are made, locally, free of constraints from national bodies, that we reduce the ever-increasing data and monitoring requirements, that we have a simpler process for agreeing M&A transactions, which I think we will see more of as we try and fix some of the problems that we've got, and recognition and opportunity to spread success. We will enable as much autonomy as possible for successful providers. We're working on a slightly more nuanced regime than the one we had at Monitor, where basically you were either in breach of your licence or not, to allow the high performers as much autonomy as possible. Obviously, those that are in the most distress, the most difficulty, there will be less autonomy, there will be more direction, more involvement from the regulators to fix the problems. But there will be some segmentation, again, coming out of NHSI over the next few months that will set out how we will effectively segment the portfolio of providers. The desire is to treat NHS trusts and FTs broadly the same. They do have a slightly different legal status, but we'd like to have an operating framework that is consistent across both sorts of organisations. What's changing and what's not? We obviously don't want to throw away the good. There are many, many very good things that we are inheriting from Monitor, from the TDA and from NHS England, which we'll be building on. Some of our core regulatory functions that sat within Monitor around pricing and competition, procurement, and continuity of service remain unchanged. There's no change in the law. There's no change in the legal licence that we regulate the FTs against. And there are no plans, I don't know what Chris said earlier because I only arrived halfway through his presentation, for the statutory role of the governors to be changed in the future. Moving on to your role, the role of the governors, it's a very, very important role that you hold. And again, no significant changes here. Holding the board, the non-execs, to account for the performance of the board, to represent the interests of the members and the public, to approve significant transactions, mergers, acquisitions and dissolutions, which was an amendment in the most recent legislation, and ensure that income from non-NHS sources does not significantly interfere with the carrying out of your principal functions. So that role remains for the FT governors. We've been asked a number of times about your role in the STPs. This is the planning process that's going on at the moment. Obviously, planning guidance has been issued, and we're collecting the short-term plans in at the moment, and the longer-term plans come in July. But I would absolutely expect you to have a role in the development and the oversight of those plans. The boards have a responsibility to share those plans with you, and I would encourage you to feed into that process. Now, we do provide a certain amount of support for governors, and there's one or two members of the NHS Improvement team at the back who I'm sure will be happy to talk to you about what we can do to help governors. I won't go through the various points here, but there is support from NHS Improvement, and that will continue for you as governors of the FT sector. And there are further resources on our website for you to read or to download. So, some closing thoughts. A very, very challenging time for the sector. NHS Improvement has been set up to support it, to get through those very difficult challenges and only use its formal regulatory powers when absolutely necessary, but they remain embedded within NHS Improvement. Monitor as a statutory entity actually continues to exist. Governors do perform a hugely valuable role, and we don't see their functions or their changing, or indeed the importance of your role decreasing. Our aim is to support you as much as we can to carry out your duties effectively. As I said, we as an organisation are very committed to this model. I think it is the right model. It's a much better model than the model that we had before 2004. And I understand there's going to be some roundtable discussions after lunch for you to discuss the sort of further support that you might require. But do tell us and Chris and his team what that might look like. And we work very closely with NHS providers. I see Chris on a pretty regular basis, and we'd be delighted to put in place the support and the programmes that you feel that you need to do your very valuable job even better than you already do it today. And that is that.
Thank you.
I'm very happy to take questions.
My name's Alan Hastings. I'm a public governor at Milton Keynes University NHS Foundation Trust. As you say, there's a hell of a lot of questions come out of what you've been talking about. The one thing I was delighted to hear is that you are talking about reducing some of the reporting requirements. So that will save us governors having to look at 70 different charts every time we have a meeting. My question is, how will you and when will you make sure that all of the executive boards of all the trusts know what you're doing and what your new role is?
Okay.
Paula Grayson set Mental Health and Community Services Trust. Back in the 80s, forgive me everybody, I watched area health authorities taking the surplus from mental health trusts and giving them to the nearby acute in deficit. Having looked at a snapshot of the new control totals, the same thing is happening, and yet we talk about parity of esteem. I'd like a thought on that, please.
My concern here is that the NHS Improvement is sort of mixing responsibilities that you picked up from Monitor with responsibilities that you've picked up from NHS England on patient safety, and it's how will you reconcile the potential conflict of interest there?
Right, regulatory burden, I agree. One of the first things that we did when we set up Monitor was seek to significantly reduce the amount of information that was being collected by a whole range of national bodies. It was something that we did back in 2004-05. There is no doubt that as the system has got into greater difficulty, that burden of information from regulators, commissioners, the CQC has increased, and we have got to keep challenging ourselves as to whether information that is collected is really necessary. My personal view is if somebody comes to me and says, we want to collect X, Y, and Z from a particular organisation or from a particular sector, my question will be, well, why? What are we going to do with it? Because only if we're going to do something with it should we collect it. Information isn't a free good. It costs money to collect, analyse, prepare it, approve it, and send it into regulators. And we have to get back to a world where we only collect data that we really need and we're going to use for. Now, this is something that we have to work with some of our partners, and there are other bits of the system that have a great desire and demand for information. We have to work together as national bodies to reduce that burden. When will trusts know what we're going to do? This was Milton Keynes. I hope they do. I saw the chief executive of your trust only 10 days ago. I think he has a very clear understanding of NHS Improvement's role and what we'll be doing in the future. We had a chair and chief execs conference in the middle of February that set out what NHS Improvement was here for and what we'll be doing in the future. So I would hope that there's already a pretty good understanding. Now, with any new body, it will take a little bit of time to establish ourselves, but we do spend a lot of time on these sorts of events and other stakeholder engagement to make sure that the system understands our role and how we will be doing it in the future. Second question was about control totals. Control totals are very much based off the outturns of prior years. We are going through a process at the moment of trying to finalise those. It isn't a perfect science. I don't think there's any significant difference in the way, in fact, I'm sure there's no significant difference in the way acute and mental health control totals are being set. The plain facts are, it's in terms of the deficits in the sector, I haven't got the data to hand, but 90% of them sit in the acute trusts. The mental health sector is by and large in a stronger financial position, as are some of the specialist hospitals. The control totals, represent not just the aspiration for 16-17, but they're obviously based on what's been delivered in the prior year. Now, very good last question, conflicts of interest. I do agree that we do have effectively a regulator and an improvement agency sitting alongside. I run the regulatory side, and as far as I'm concerned, it is independent of the improvement side. And if regulatory action has to be taken, whether it is competition or continuity of service or an intervention in an FT, it will be taken regardless of what other improvement work has been done in another part of the organisation. And we will set up our committee structure, our governance, to ensure that that is the case. But it's something that we are well aware of. To some extent, it did exist in the past as well. But different people, appropriate governance structures will ensure that there aren't conflicts of interest that become a problem.
Trevor Parkinson here from Hampshire, Public Governor. A question in two parts for you, Stephen. Firstly, you've been flinging out some very large numbers for your organisation.
Sorry,
You've been flinging out some very large numbers for your new organisation. Can you give us some idea as to how much that's actually going to cost and how you're going to measure your own performance? And second part there is, you're talking about an integrated service. We're measuring performance for individual trusts. Is there any plan to measure perhaps an integrated service in various areas as to how people might be performing across the primary, secondary and local authority care?
Ian Clay, I'm a volunteer governor. I represent the volunteers at the Royal Berks in Reading. Two parts. We seem to hear a lot about the foundation trusts, but very little about the growing number of CCG federations that are carrying a deficit of more than £5 million. If we don't have the people to pay us, we can't offer the services at the other end. And the other one is we keep hearing time and time again that things like the 30-day rule are being reviewed, i.e. if you send a patient out, they come back within 30 days, you have got to treat the patient, but you're not going to get paid for it. And as far as I know, the figure for last year is just below 100 million.
Thank you. My name is Mary Fodingham from Pennine Care NHS Foundation Trust, which is a mental health and community service trust. My question is you mentioned that competition wasn't going to change. How will that fit in with devolution, such as in Greater Manchester and Vanguard sites, where people are working together rather than competing?
Large numbers being banded out. I can't tell you what NHS Improvement's budget is going to be at the moment because it's not been agreed with the Department of Health. What I can tell you, if you were to take the constituent parts and add them together and then deduct a reasonably significant percent, you'd get close to it. What I can tell you is broad head count. And I think the head count for NHS Improvement will be somewhere between 800 and 950. But as I say, at the moment, negotiations are ongoing as to what the overall budget is going to be. How will we measure our own performance? Well, we will do what we did at Monitor. We will agree with our board a set of objectives, and we'll measure ourselves against those objectives and publish our performance. But for me, our performance really is about making sure that the sector improves, and therefore, what matters most, whatever we come up with as a new board, as I say, that hasn't met yet, as to the actual objectives and how we measure that performance, I would be expecting us to see improvements in the sector in terms of its quality as measured by the CQC. I'd want to see more trust getting good and outstanding and fewer in special measures. We're going to want to see the key access targets improving and not continuing to decline, and we're going to seek to get the system, particularly the provider system, back into the black and out of the red. So, to me, as I say, those are the key areas of performance that, as a member of NHSI's board, that I will want us to deliver against, however we ultimately set them out in our annual report. Question about CCGs and deficit. I don't honestly know how many. You talked about one being 5 million in deficit. I totally agree that CCGs have got to be solvent to pay the bills of the providers, and the brutal fact is that the CCG financial position, the commissioning side, is nowhere near as dire as the provider side, and there are all kinds of reasons for that I would discuss with you over coffee, but not in public forum. And I'm sure Chris would do the same. There's a fining system, and there's tariff rules, all kinds of reasons as to where the deficits fall. And of course, this is broadly a closed pot of money. But I think you'll find that in 16-17 there'll be a bit of redress of the balance because of the way the tariff and the fining system will work going forward. It's quite a complicated area. The 30-day rule not being paid. Look, I have to say, I do get a little bit frustrated with some of the organisations that you represent. Many years ago, I worked for KPMG, the accounting firm, so I come from the commercial world. If your organisations do work to an adequate standard, they should be paid for it. And sometimes they don't get paid, and sometimes they enter into contractual arrangements that, frankly, I wouldn't enter into. And I think you can help me by encouraging them not to do that. I mean, there has to be tension in most commercial relationships, and I think there are occasions when too many providers are done over by the commissioning side, because the commissioning side is the bit of the system that's got the checkbook. So I would encourage you to ensure your boards don't enter into block contracts that give all of the volume risk to the provider and allow the commissioner to walk away from some of its responsibilities. So that would be my answer to that question. A very tricky question about Vanguard's devolution, competition and our regulatory approach, and I can't give you a complete answer. We are looking at how we will regulate going forward. At the moment, we've got to come up with something that will work for the individual providers in 16-17, but I'm absolutely conscious that as we have systems that are, where we have providers that operate in complex systems, we need to start to think about the extent to which we can oversee, regulate the health service in a more place-based way. It's not easy, and I don't have an answer standing here as to how we're going to do that. We are, on Manchester Devolution, we're heavily involved in discussing how that would work and how that will work going forward. We're also involved in the creation of some of the chains, and conversations again going on about how that regulatory oversight regime will work when we've got potentially multiple sites in different geographical locations. Some of this is not straightforward, but I don't like to say we are working on it, but that is the case. But I don't have a straight answer as to how it will work in the future, but it's in development.
Maureen Harrison, NHS, Stockport NHS Foundation Trust. I'm wondering why Monitor, now NHS Improvement, and the CQC are still operating as independent entities. And I'm wondering, when should they merge? And don't you think it would be a good idea if they did merge? I think, wasn't that a recommendation of the Francis report?
Hello, my name is Ferguson McQuarrie. I'm from CWP on the Wirral. Just talking about the governors. At the moment, we're implementing young people to stand on as governors. And we've had quite a lot of correspondence back from the young people. And hopefully, within the next, next couple of months, we'll be having at least 2 young people as governors on the board. I was just wondering, do you think that's a good idea? And is that a way forward?
Okay, Stephen.
Right. CQC Monitor merger, it's been debated and discussed on a number of occasions over the last 10, 12 years. It's not ultimately our decision, it's a decision for the government. The government decided in sort of the summer of last year that it wanted to bring the provider oversight functions of TDA and monitors together. So, the cop-out answer is it's not my call. It's a more helpfully, it's a difficult issue, this. You can make the argument that you bring effectively sort of quality inspection and regulation and financial oversight together in one body. It creates efficiencies. You can also make an argument that says, isn't it better that you have them in different bodies so that there is never any potential for arguments over money and efficiency to trump the view of quality of care. So this is something that can be argued both ways. There is an argument to put the two together. The government decided it doesn't want to do that. There's also an argument as to why your economic, financial regulation and oversight should be separate from quality, oversight and inspection. The second question, the legislation allows governors to be 16? Somebody help me, is that right? 16 and above. Do I think it's a good idea? Absolutely. I do. And I mean, I've got a 15-and-a-half-year-old myself, and I think he's got some very interesting ideas, and I'm sure he would, who's interplayed with the health system quite a lot, in 6 months' time make a good governor if that's what he wanted to do. So I'm all in favour of young people and young service users representing populations of providers. Clearly, as with anything, there's a point at which it wouldn't work. I've also got a 12-and-a-half-year-old. I wouldn't recommend my 12-and-a-half-year-old in any organisation at the moment because he's a grumpy little young man going through puberty. So, look, I think it's a great idea. I'll leave it to others to work out what is the appropriate age. 16 seems a pretty good point to me, and I would encourage them to be involved in our health service.
Thank you, Stephen.